These interviews being done here at the Massachusetts General Hospital are part of the program of the Archives Committee of the American Association of Neurological Surgeons to record for the future the thoughts, the philosophies, the background of some of the leaders in American, not only neurosurgery, but neurology and other neurosciences. I'm Dr. Robert Ojemann. We're here at the Massachusetts General Hospital, April 20, 1988, and I have the pleasure of interviewing Dr. William Sweet, former chief of the Neurosurgical Service here at the Massachusetts General Hospital and professor of surgery at Harvard. Dr. Sweet, it's a real pleasure to have you here today, particularly since I owe a great debt to you for my neurosurgical training and my background. I thought we might begin by having Dr. Sweet tell us a little bit about his background. He grew up in the Northwest, and it's of interest as to how he became interested not only in medicine, but also particularly in neurosurgery. And Dr. Sweet, why don't you begin by telling us a little bit about your earlier life?
It's customary for many folks to say that they owe a good deal to their mothers. In my case, this is peculiarly true because my father, right after finishing his MD with his Methodist religious background, decided he should be doing some missionary work, went out to provide medical services to men working in the logging camps and sawmills of the Cascade Mountains. And his wife, my mother, was in the unusual situation of being a university graduate, unusual in those days, and she had absolutely nobody to talk to in these logging camp areas. So she talked to me as soon as I became able to utter words, and gave me roughly the first 3 years of the grade school education before I ever started a grade school at the age of 5½. So that in a couple of years I had gone through 4 grades of school. We then moved back to Rochester, Minnesota, where my father decided he needed more training as a fellow there at the Mayo Clinic. And my mother had taught me well enough, so I went right on into the 5th grade at the age of about 7½, and went on to finish high school at about the age of 14, which gave me a sort of a head start. That
must have been remarkable at that time. I don't suppose many people did that.
Well, it was an unusual situation, of course, but in my high school years, I was in this, as you might...
You were back in Washington then for your high school?
Oh, yes, by now for high school, and we're back in Seattle, Washington.
Right.
And I was too small to take part in any athletic events, but so were the Japanese boys who constituted a consequential part of that high school population. And I became very well acquainted with them. They were my closest friends and also my competitors in school.
What year are we talking about now?
Well, this is 1920 to 24.
Okay.
The Japanese boys worked hard, were friendly, but their main objective was to do well at what they were doing. So I had the experience that has been a little more common throughout this country now in the last 15 years of competing with the Japanese. And it was very good training for me.
Sign of the future. Then what was your next educational endeavor? What was your next step?
Well, my next maneuver, having finished high school at the age of 14, was to spend a year essentially doing nothing but playing the piano in extension of piano lessons taken earlier.
Well, now you had some thought at that time about perhaps even being a concert pianist, I've heard you say.
Well, that's right. I hoped that this would be the beginning of my career as a concert artist. And 1 year, I'm sorry to say, sufficed to convince me that I did not have what it took. I would never be a concert artist on the piano.
But you subsequently were in the operating room, which was a big benefit to all of us. Well, go ahead then.
Well,
after that year.
Yes, my father decided that I'd been doing entirely too esoteric a sort of thing, that I should take part in what goes on in the lives of most of us. Had me work for a year in a sawmill. In its way, a very instructive year. Assembly line tactics were the order of the day there. And I found that not only I, but the older men with whom I was working rapidly developed the ability to do their jobs on an assembly line without even thinking about it at all. The tasks were so routine, so stereotyped, that none of us had to pay any attention to what we were doing, and we all tended to live, I found, rather fantasy lives in which we were thinking of ourselves as great achievers in everything we thought of doing. And I thought from this, as I've ruminated on it later and then at the time as well, that gives us all a rather exalted impression of our abilities because we imagine ourselves to be so perfect. And that maybe this is the reason that negotiators with workmen on assembly lines find them so intransigent, because they think of themselves in such noble and highfalutin terms. At any rate, I decided that this was not a good way to spend time, and early on was introduced to the concept that I better concentrate on using my time more profitably.
So you went to college?
Went to the University of Washington, and there my bent toward medicine as a consequence of my father's influence was competing with what developed into a great interest in aviation. I should say that the University of Washington, early on in those days, had a good school of aeronautical engineering.
This is the late 1920s now.
This is now the late 1920s. We all know about the Boeing Airplane Company in that area, having been a very potent competitor in the field of aviation. And consequently, I took the opportunity provided by the United States Navy of ground school training at a few of the universities that have nearby a smooth body of water on which military pilots can learn to fly seaplanes. So I did
Lake Washington.
Lake Washington, yes, that's right at the University of Washington. And so having finished my ground school and being in the first group to get flight training, the tactic was that I was going to spend 8 months as a flying cadet, a year of active duty in the fleet, and then flight practice in the reserve for 2 or 3 weeks a year thereafter. But in those days, flying wasn't so safe. And there was such a high mortality among these men coming back to have 2 or 3 weeks of active duty with the fleet that they increased that period of active duty requirement to 3 years. And I realized I had to make up my mind. Would it be flying career, aviation, or would it be medicine? My decision was based on what seems to be a remarkable kind of set of facts. In 1930, it was inconceivable that in my flying lifetime there could be a war. There wasn't anybody for the United States, Britain, and France to fight. They were all getting along very well with each other, and no other significant power was on the horizon. So, no use in being a military pilot if you're not going to have any war to practice in. So, it seemed to be a greater likelihood of having a steady clientele of sick people. So I went into medicine.
And that took you to medical school where?
came back to Harvard Medical School, and there I encountered the charismatic, brilliant figure of Harvey Cushing. He was the senior professor of surgery, the Moseley professor of surgery at the Peterborough Brigham Hospital.
He was in the last few years then of his active work there.
Yes, he became 62 in 1932, and at his order, along with Henry Christian, the professor of medicine, 62 at that point was the retiring age of the Brigham. So I only had an opportunity to see him in action for 2 years, but that was a very impressive set of observations.
And that was an important influence in steering you to the neurologic field.
Yes, it was, Bob.
You interrupted your medical school career with a Rhodes Scholarship. Perhaps you could tell us a little about that.
Well, I was keen to go to Oxford if I could, because the outstanding neurophysiologist of the world at that time, probably the top man, was Sir Charles Sherrington in Oxford. And I hoped to do a doctor of philosophy in neurophysiology under Sir Charles. A remarkable tragedy prevented that. Just shortly before I was to start that training, Lady Sherrington totally unexpectedly died, and this had a devastating effect on Sir Charles. For one whole Oxford term of 8 weeks, he was going to be coming down to the laboratory each morning. I would come into the laboratory. He wouldn't appear. And finally, at the end of that 8-week term, his library was on sale in Blackwell's, and one of the Oxford physiology dons said to me, "Sweet, I don't think Sir Charles is going to come back to the laboratory." And he didn't. So
that certainly was a keen disappointment, I'm sure, but you did some other things.
Well, I went on and did a minor research degree called a Bachelor of Science in Oxford in physiology, looking at the blood vessels on nerves, readily seen, of course, against the white background of the nerves, and studied responses to them. But I spent the 28 weeks of an English academic year on vacation.
Oxford's normal term, as I understand from your what you said, was 3 8-week courses and then the rest vacation.
That's right.
How did you spend that?
Well, I went to Würzburg, Germany. This was the university in which Wilhelm Conrad Röntgen had discovered the X-rays and had a history of achievement in academic medicine. It was a bad time to become acquainted with Germany. Hitler became Reichskanzler in February of '32, just shortly before I first appeared in Würzburg. And I had the really shocking experience of seeing the way in which this capable, intellectually accomplished group of people simply slipped back 1,000 years in their moral conduct, with the results that we all know about. I left Germany angry at the end of the summer of '34, feeling I'd probably completely wasted my time. But I did not totally waste it. At least I learned enough German so I could take the German government examination in internal medicine before I left.
And I understand get a 1, which is, I guess, the highest category of grade that you could get.
Well, I guess that's right.
Which is a real accomplishment in itself. So then you came back to Boston.
Came back to Harvard Medical School.
And completed your training here. And you still were bent on the neuro science field. Had you pretty much decided to be a neurosurgeon at that point in time? Or?
I was, however, the more inclined towards surgery than basic neurophysiology because of the fact that during my animal preparations, preparing the cats for the observations I made on them at Oxford, I used the tactic that was absolutely mandatory in Sherrington's laboratory of preparing an animal for physiologic observations, not by giving the animal a sustained anesthetic of any kind, but by doing a decerebration section, cutting through the midbrain between the colliculi to provide the necessary anesthesia for the animal. And about half the animals died prematurely from this rather crude operation of simply a guillotine slice through the midbrain. And I decided if you're going to be a neurophysiologist, you'll have to learn how to do the surgical procedures that are involved in getting the animal prepared for the experiment. But I also thought, well, psychiatry is a component of study of the nervous system. I must find out what the psychiatrists have to offer. So I got a job for my board and room at the Boston Psychopathic Hospital, now more euphemistically called the Massachusetts Mental Health Center. But I decided after my year and a half there that the field was far too nebulous for me to be able to make any contribution in it as far as I could see. I was led to that conclusion the more by Sherrington's behavior. When he, among his earlier physiologic studies, stimulated the cortex of primates and found the motor cortex and the responses to stimulation therein, he decided this was far too complicated a situation to make any real headway with, and he devoted his entire experimental career to studies on the spinal cord and wrote the integrative action of the nervous system on the basis of spinal cord experiments. So I was inclined to think that I'd better try to do something in which there can be some kind of a reasonable step forward fairly soon, rather than wandering around in what seemed to me to be a complete morass of ignorance, which I'm afraid was my idea, at least, of psychiatry at that time.
Sounds like good judgment on your part. After you completed your medical school training, then you took a surgical internship, I believe, at the Brigham?
Well, actually, my last 6 months of medical school, I was allowed to function as a house officer in neurosurgery at the Mass General. The individual in that post became ill, and by this time I'd already been in medical school 5.5 years, so I had this 6 months as a neurosurgical house officer at the Mass General to give me now an opportunity to decide if I really wanted to go into neurosurgery, and came under the influence of Jason Mixter and Jim White and John Hobson as well. These three very different, but each in his own way very capable individuals, crystallized my thought that neurosurgery is what I'm going to go into.
And then?
I went on out then to the University of Chicago for that, with a view to getting neurosurgical training there, because on that service at the time, Percival Bailey was the chief, but two other individuals who were shortly to become very distinguished, Paul Bucy and Earl Walker, were also members of this rather small service with about 15 beds. So the contact with
quite a remarkable group.
Yes, it really was.
Well, now somewhere along the line you took the last year of your Rhodes Scholarship. When did that occur?
Well, that followed on getting the standard neurosurgical training at that time, namely 1 year of neurology and 1 year of neurosurgery at the University of Chicago. And then I came over to Queen's Square in July of 1939 to do a year, largely of research was the plan, under E. Arnold Carmichael, an inspiring individual, and as well to see how they did neurology at Queen's Square. But this character, A. Hitler, had plans that changed the lives of a good many of us.
Why don't you tell us a little bit about how it altered your life.
Well, in the middle of August of 1939, the Russians and the Germans signed a non-aggression pact. And that to the British government was a signal that war was unavoidable. And they managed to convey their realization of that fact to the British people by a means that we don't have in this country. They had a so-called stop press edition of their newspapers, that's to say an extra paper, announcing this non-aggression pact. And that let the British people know that war was at hand. I came down to the hospital the following morning, and to my amazement, there were women in tears on the underground. We got to the hospital, and the equipment which we had set up, carefully getting it all lined up and ready to go in about 6 weeks of effort, we now dismantled and put into boxes. Spent the day doing that. And at the end of the day, I found that the National Hospital was devoid of every patient who could possibly be moved. They'd been moved out in buses whose seats had been removed and accommodation made for holding stretchers, moved to hospitals outside of the London area.
And all this literally happened overnight.
This literally happened in this extraordinary short time. They were ready, they were on a war footing within an extraordinarily short period of time.
So what did you do then?
Well, I learned that Hugh Cairns, the Nuffield professor, neurosurgeon at Oxford, was the head of the British military neurosurgery. So I went to Oxford, and he signed me up to be the head of one of their mobile neurosurgical units. But the month of September went by with Germany overrunning Poland, and then the war apparently came to an end for a hiatus. The so-called phony war, it was called at that time. There was nothing for me to be doing in Oxford. So I went around to Brigadier General Cairns and said, don't you think I better go back to the United States? He said, well, as a matter of fact, we don't have anything for you to do here, sweet. I guess you better. So I did come back to the University of Chicago, who kindly accepted me back, and shortly went, as a consequence of their assistance, to a Commonwealth Fund fellowship back here in Boston, out at the medical school, where I worked with a classmate, Dr. Stanley Bennett, who had gone into a career of full-time investigation after a year's medical internship at Hopkins. And we did work trying to develop a thermocouple flow meter system to assess changes in blood flow.
You also, so shortly after that, had an opportunity for some clinical work as well.
Well, that opportunity again came about by coincidence. The medical resident, the neurosurgical resident at the Mass General, Henry Heyl, volunteered to be the neurosurgeon at the University of Birmingham, England's Queen Elizabeth Hospital, where they had no neurosurgeon in Birmingham at all, needed one. Henry went over to do that job. And I then sought to fill in for him as neurosurgical resident here while trying to do research out at the medical school as well, and found that if one is going to be doing clinical work in neurosurgery, that takes precedence over other activities. So I didn't do my share of the investigative work out at the medical school as I sought to do a decent job as a neurosurgical resident here.
But shortly you were off to England again.
Well, what happened there was that Henry Heyl left the Queen Elizabeth Hospital. Again, they were without a neurosurgeon. And I didn't finish the residency here, went in the autumn of 41 to the Queen Elizabeth Hospital in Birmingham, where I spent 4 very active years being the only neurosurgeon for 4+ million people in the British Midlands.
that certainly was a full training period in itself of 4 years, I'm sure. Then you returned to the United States, and perhaps you could briefly summarize the next several years of...
Yes, I might mention the fact that during World War II, I had a remarkably happy opportunity to become very well acquainted with Geoffrey Jefferson. He was not yet Sir Geoffrey Jefferson in those days. He was the head of the British Emergency Medical Services neurosurgical efforts throughout the United Kingdom. And I needed help on more than one occasion, I may say. And I had the privilege of going up to Manchester to get some special tutorials from him as well. Brilliant man, brilliant neurosurgeon. But as you say, the war ended, and I came back to this country, happily, fortunately for me, to this institution.
Where you spent a remarkably productive career. Perhaps you could highlight for us some of the important accomplishments you participated in. I might point out that we have on the table here the 1st and 8th volume of Dr. Sweet's reprints, the clinical neurosurgery, which contains the publications when he was the honored guest of the Congress of Neurological Surgeons, his classic book on pain, written with Dr. White, and a more recent endeavor with Dr. Schmittick on a very comprehensive volume of operative techniques in neurosurgery. But Dr. Sweet, one of the things that has highlighted your endeavors to all of us is your ability not only as a superb technical neurosurgeon, but also your ability to converse in a scientific manner with a neurochemist, a neurophysiologist, a physicist, and this is a attribute that certainly has stood you well. But perhaps, again, you could indicate to us or highlight what some of the important areas were that you felt that you made accomplishments in.
Well, one thing that impressed me from my Oxford experience was the value of becoming well acquainted with the physiologists in particular, and to some extent with the chemists as well, the biochemists. In fact, I was sufficiently impressed with that so that when I was planning on returning from Britain to this country as the war was ending, my wife wired me that there was a house available that we might think of buying, and I asked, well, who would the neighbors be? And she said, well, immediately adjoining us is a biochemist called Hastings. Well, the biochemist called Hastings was the chairman of the Department of Biochemistry at Harvard. I already knew from his reputation and his abilities that it would be terrific to be anywhere near him, and I cabled back, buy the house. And there began a very fruitful period of association with this very remarkable man who became my personal scientific advisory committee. And one of the things he had done was to recognize the importance of radioisotopes to medicine. At that point, their availability for medical purposes was in its infancy, but Professor Hastings recognized that this was a tool that was going to be of great value, and he succeeded in getting set up at Harvard the biophysical laboratory under Arthur Solomon, whose tutee I became as soon as I could, and in fact was so impressed with the potential of this field that although I had earlier decided my research after the war was going to be trying to develop the Horsley-Clark stereotactic method for man, and had done some preliminary work out at the University of Illinois' Neurological Institute, got a grant from the Rockefeller Foundation to do this, but then became so excited about the radioisotopes that I gave the money back to the Rockefeller Foundation and went on to work with radioisotopes instead.
You were certainly one of the pioneers in radioisotope scanning, and then in the application of radioisotopes to treatment and radiation therapy to treatment. Perhaps you could give us a little more detail in how you came to those investigations.
The basis for starting out on this then was, as I've indicated, an awareness that it would be possible to find the rates at which various physiologic and physiopathologic reactions took place with this safe method, so that we began by giving sodium-24 and heavy water, deuterated water, to patients, and measured the sodium-24 and the deuterium concentrations in blood and cerebrospinal fluid, and found to our amazement that especially the water exchanged with extreme rapidity between the blood and the cerebrospinal fluid, that the half-life of this exchange, for example, for water and between blood and cerebrospinal fluid to reach equilibrium was about 8 minutes for the deuterated water and only about 10 times that long for the sodium-24. Indeed, this exchange, this crisscrossing back and forth of the molecules, was so rapid that clearly this didn't indicate then net flow of water into the cerebrospinal fluid, that the net transfer couldn't be measured then by using these isotopic measurements. But we went on to try and bring this into clinical focus for somebody interested in tumors, and gave the then most readily available compound, phosphate, labeled with P32, the beta-emitting P32, and found that despite the fact that phosphate's obviously important to the normal brain, that it entered brain tumors vastly more rapidly than it did the normal brain. And I'm happy to say that you joined us ere long in the use of these isotopic methods to study the whole problem of localization of these isotopes in various forms of cerebral intracranial disease. Our first finding was that we ought to be able to spot with a beta-counting probe whereabouts within the depths of the brain this substance, this mass was that was taking up the P32. And for a time, until we had better methods, the use of a probe put into the brain after the patient had been given some intravenously, some radiophosphate, enabled us to find a deep-lying tumor that we had been more uncertain about where to go for prior to this time. But the P32, the electrons emitted by that, wouldn't penetrate the skull, so we needed a gamma-emitting radioisotope to go through the skull and localize by appropriate detector methods where the higher concentration of this gamma-emitting radioisotope was. However, the gamma rays tend to scatter a good deal as they traverse matter, And here, working with Dr. Gordon Brownell, we conquered this problem of scattering of the gamma rays by the use of so-called positron-emitting isotopes. Gamma isotopes that decay with the emission of a positron rather than an electron results in a particle that survives a minimum of time. It soon encounters one of the myriads of electrons orbiting atoms in the tissue, and the two particles disappear as mass and are replaced by a pair of gamma rays that leave the site of the annihilation back to back, so that if one has apparatus that will count so-called coincidences, detect each member of the gamma ray pair, will then find out where they are inside the head.
Well, the development of all this really at that time was remarkable, I think, for the younger neurosurgeon who has now the convenience of CT scan and MRI scan. They don't realize what things were like at that time. Dr. Sweet, you were a pioneer in the application of boron in the treatment of brain tumors. Perhaps you could summarize your concepts in that regard.
When we found that the phosphorus-32 concentrated in brain tumors so well, we thought, well, maybe we can use this beta particle to kill the tumors. But we found that in addition to the brain tumors, bone marrow, liver, and other rapidly metabolizing tissues also concentrated the P32, so that that was no good, and we realized that we had to have something that would take advantage of the blood-brain barrier, but itself be innocuous until something else happened to it. And one day I came across an article pointing out that all of the radiation injury in a lily bulb that ensues when it's bombarded with slow neutrons is because of the trace amounts of boron in the lily bulb. And I said, by gosh, that's what we're after. We're after something that converts an innocuous substance into a lethal substance. And it turned out to be even more lethal than I realized, because when the boron atom, the boron 10 atom, captures a slow neutron, it disintegrates into two other heavy particles that don't go anywhere beyond the diameter of about a red blood cell. So the tumor cell that took up the boron atom is the one that is damaged by these two very energetic heavy particles that arise as a consequence of the disintegration of the boron atom. So that's the basis for efforts to treat brain tumors by an appropriate compound of boron injected into the bloodstream. And it's taken us a very long time to try to bring this to fruition. But a Japanese investigator who worked for 3 years with us here is the man who kept being supported by his government when he got home to keep the whole project alive. And now there are about 6 or 8 laboratories around the world who are concentrating on trying to bring to fruition this concept of boron slow neutron capture therapy of brain tumors.
Well, that certainly was a very unique concept, and one that still holds significant promise. You've been involved in a number of other research activities. I'd like to have you talk about some of those.
Well, it's not too bad an idea to talk about those that didn't pan out, so that people won't realize that it all is hunky-dory from start to finish. The work that Stanley Bennett and I did, for example, on the thermocouple flow meter came to naught because we found that the method really isn't a satisfactory one for measuring blood flow, for example. However, a series of studies embarked on originally with Percival Bailey on stimulation of exposed portions of the brain has panned out to be useful. We found that on stimulating the back part of the orbital surface of the frontal lobes in a cat after the orbital contents had been removed, that we would produce changes in respiration, blood pressure, and gastric motility, and that on stimulation of the tips of the temporal lobes, similar manifestations would occur. And this has led me, along with Dr. White, to use stimulation methods for nerves, both sympathetic and somatic, and within the central nervous system, both the spinal cord and the brain, within the brain stem and on the surface of the cortex, to establish the functions of these different areas by means of electrical stimulation in the awake patient. Another tactic that interested us, and indeed in which we carried out the first operation in man in a patient whose temperature was reduced down to 26 degrees centigrade, because one found that at this low temperature it was possible to occlude both carotid and both vertebral arteries for a substantial interval. And in our second patient, we were able to occlude all 4 of those trunk vessels for a total of 45 minutes over a 2-hour period, during which periods of total occlusion we could carry out the necessary manipulations to remove a deep, massive AV malformation. For a brief interval, several years, the concept of doing any kind of bloody operation in the intracranial cavity under hypothermia held sway. But this rather complicated maneuver, with its disadvantages in connection with increasing cardiac irritability, didn't last too long, and better methods have been found to achieve this objective of enabling bloody lesions to be tackled successfully in the intracranial cavity.
But again, at that time, it was a very important step forward. You, as you look over the 4 decades of your work in neurosurgery, are there areas that you see that for the future that you think are going to be where the most advancements are going to be made, or where we're really going to make some progress? How do you assess that situation?
Well, I think that an initial observation by Pat Wall, and in which I joined in, that we can stimulate pain suppressor mechanisms in the central nervous system to control chronic pain, may hold the key to much further advancement than we're now able to make. We did find, and this has been repeatedly confirmed by stimulation of many parts of the brain and spinal cord, that there are indeed pain suppressor mechanisms that can be activated by electrical stimulation. However, on the whole, the tactic has been somewhat disappointing, I think, for this fundamental reason, that every single nerve cell has playing on it activator and suppressor influences. All of those may be called into action by the non-specific fact of an electrical stimulation, so that you have to be lucky and have that effect that you are seeking to achieve, activation or suppression as the case may be, predominate when you electrically stimulate. But we now know that there's not one, but a bewildering array of chemical neurotransmitters, each of which at any given site will either be activator or suppressor. They won't do both the way an electrical stimulation might do. So what we need to do now is find out which of the numerous neurotransmitters are to be applied where to produce the therapeutic effect we're after. And we're aided by this very fundamental feature of the central nervous system, that there's this tremendous so-called redundancy. Several neurotransmitters having very similar effects at the same site. The value of this was first brought home to me in an entirely unrelated connection. I was serving on the Scientific and Technical Advisory Committee to the Office of Manned Space Flight during the Apollo program. And the engineers there were given the task of bringing the astronauts back with 999 chances out of 1,000 of no failure of the equipment. And the engineer said this is absolutely impossible. No such engineering device has ever been created that has that kind of fidelity. But they had the thought, well, we can make a device that will have only 1 chance in 10 of failing, and we'll have 3 of them. So when the first one has failed, you go to the next one, which has only 1 chance of failing, and the third one finally has only 1 chance of failing, so you finish with 999 chances out of 1,000. Well, evolution has clearly achieved that probably to an even greater degree in man, in the brain, and the control systems, but we just need to learn how to use that information, finding out which neurotransmitters to put where, and this is where the neurosurgeon comes in, because he's the chap who puts the neurotransmitter at the crucial site within the substance of the brain.
Before we close by talking about some of your awards, are there any other areas that you would like to comment on where you have either made clinical observations or done research?
Well, I think that as we're talking about what the future may hold, it's clear that supplying to the brain cells that will themselves manufacture the appropriate neurotransmitter is certainly an extremely exciting kind of vista. I've just returned, as a matter of fact, from a meeting of the Society of British Neurological Surgeons where Dr. Hitchcock described the transplantation of the midbrains of 2 human fetuses to patients with Parkinsonism. And one hopes that this is the kind of neurosurgical maneuver for the future that will enable us to manage many disorders now totally unmanageable.
And this particular event, as Dr. Sweet has just described, namely his going to a meeting, keeping up to date with the most current findings and accomplishments in the neurosciences, has typified his career. I know one of the honors that you cherished most was being the honored guest at the Congress of Neurological Surgeons. We've already alluded to the clinical neurosurgery. I believe the tie clasp you have on also honors you in that regard. Tell us about the tie itself.
Well, I'm eager to do that. The Royal College of Surgeons of Edinburgh, the oldest of the Royal Colleges in the United Kingdom, has an honorary fellowship, and that college, founded as indicated on the necktie in 1505, kindly honored me with its honorary fellowship a few years ago, so I thought this was the time to wear that necktie.
One of many honors that Dr. Sweet has received over the years. Dr. Sweet, one of the other honors you received was this Forster Medal. Perhaps you could tell us about this inscription that we have in this booklet.
Thank you, Bob. The Deutsche Gesellschaft für Neurochirurgie, the German Neurosurgical Society, has what it calls its Otford Forster Medal, and they've only given out 3 of these in North America, one to Wilder Penfield and one to Percival Bailey, and I feel very lucky to be the 3rd recipient of this honor of theirs. I was the more grateful, as a matter of fact, because I've been very critical of the first professor of neurosurgery in Germany, who became an ardent Nazi, and I'm pleased to infer that being a critic of an ardent Nazi, even if he was a neurosurgeon, doesn't disqualify one for receiving an honor from the German Society of Neurosurgery.
In closing, Dr. Sweet, is there any comment you'd like to make?
Yes. I think that the present time is the luckiest time to be alive for anybody interested in the human nervous system since the dawn of history. And I wish I were at the beginning of my career instead of so near the end of it.
It's a pleasure, however, to still have you so active. Thank you so much for being with us.
Thanks for the chance to be here.
You're quite welcome. I'd like to thank Dr. Sweet for taking the time to be here today and give us his thoughts on and a summary of what has been a truly remarkable career by one of the most distinguished neurosurgeons.